Hello, welcome to Health Alert. I'm Pam Butler. Today we're going to talk about breast cancer, and joining me is Dr. Mohammed JanJua. He's with the University of Oklahoma Hematology Oncology Department. Welcome to the program, Doctor.
Thank you for having me, Pam.
Now, before we begin exactly, tell our viewers what is hematology, oncology, and why the combination?
There is a lot of overlap. Many years ago, we used to have separate hematologists and separate oncologists, but over time we decided, it was a necessity. Hematology is basically the study of blood, which is clotting problems or anemia. So as the blood becomes, there's always a problem that there's the blood benign problems become malignant. So when the transition happened, we decided to have a merger of the two groups between hematology and oncology. So hematologist not only takes care of the malignant hematology, which is the blood problems, but they also take care of benign hematology, which is clotting problems, anemias. So any problems that you have which are benign as well as malignant, a hematologist is able to take care of. But oncologists mainly take care of solid tumors such as breast, colon cancer, pancreatic cancer, brain tumors, things like that.
Okay, now tell us too, because some people do understand the distinction, but some may not. Benign and malignant, you mentioned the two things.
So, say for example, if you have somebody, or if your aunt or uncle has anemia, so what you have is a benign problem that it does not need an oncologist for, or malignant. It's not a malignant, it's just a benign, not really a complicated issue. So basically, a hematologist takes care of those, as well as if that transition from benign, a normal becomes abnormal, they're able to transition into. So any problems related to the blood, a hematologist is able to handle.
Okay, could we also think of benign as something that maybe is not as life-threatening,
right,
compared to malignant being a little more life-threatening?
Well, benign
but it doesn't have to end up being taking your life.
Benign can definitely be life-threatening. So, for example, people with clotting problems, or lack thereof clotting.
Okay.
So we have, say for example, people who have sickle cell anemia. A hematologist takes care of those. People who are hemophiliacs, that means they do not have a factor, or they have an abnormality of the factor. So they're not able to form clots, so those people bleed. So yes, definitely people who have benign problems can die of those problems. So there can definitely be life-threatening issue with either of those two. But so it was back in the day, there were two separate boards, but with the necessity they decided to merge the two. And so that's why, but there are some physicians in the community who are just oncologists. So where I was trained in Kentucky, we were trained in both hematology and in oncology. So it's a 3-year training. After completing your basic medicine training, it's a 3-year training beyond that. So at the end of which you take the two boards. You might not want to take the hematology and just stay with the oncology, but like my Chinese boss, Dr. Yam Lung, if he's a very smart guy, so he would say hematology is the appetizer. It doesn't bring bread to the table, but oncology does. So that's why hematologists have to be an oncologist, because it brings bread to the table. But appetizer is definitely the hematology. It's very intricate. It's very interesting.
And that's good to know, because you can then see one physician.
Absolutely, with all the problems.
For all of those kinds of problems, which is a good thing for us as the consumer or the patient.
Absolutely.
Now let's get to Dr. Mohammed, if I may call you. I'll drop off the JanJua part, because I may mess it up after a while.
Like I said, it took my wife 2 years to understand that.
Right. And we talked about what she missed JJ for. Americans, we like to kind of sort of give you little nicknames and acronyms. But okay, with breast cancer, let me ask you about sort of the prevalence of it. Is it really a very prevalent disease? Kind of like, how does it fall in the hierarchy of the diseases for women?
Well, breast cancer is one of the highest, so number one cancer in women in the United States. Almost 400,000 women will be diagnosed with breast cancer in the United States in 2011. almost 40,000 will die of that. So that's the highest prevalence. The biggest killer is lung cancer, as we all know. Lung cancer, you smoke. But the second biggest killer is breast cancer. So it is the most common cancer prevalent in any state of United States.
Okay, now, is it on the increase, or has it pretty much always been this way? Tell us a little bit about that, because we do hear more about it.
Absolutely. It's a very interesting question. And I get to answer that any physician gathering. So breast cancer has been there forever.
Okay.
But now we're able to diagnose it better. We're able to diagnose it much earlier. We have sensitive tests which pick up cancer which is the size of a pea, and we're able to put a needle in that. So it's just the sensitivity of the tests are improving. Interestingly, back in the day, for example, they used to start their menstruation at 11 and their menopause around 50. So if they did not have kids or they did not breastfeed, the exposure to estrogen and progesterone is much more.
Okay.
And breastfeeding is, according to data, it matures the breast, and the risk of breast cancer decreases when you have kids and you breastfeed, because the tissue, the breast cell, the ductal cell, which is the most common type of breast cancer in breast, it matures. So the more the woman breastfeed, studies have shown the lesser is the risk. But again, the jury is out on that. So the lesser the exposure to estrogen and progesterone is, the more the exposure, the more the risk. Other risk factors, there are definitely genetic mutations. I'm sure you've heard the BRCA. They're doing that in Walmart also. No, that was a joke. They don't do that at Walmart.
I was going to have you explain that one, Doc.
Okay.
Like, I've seen a lot of stuff in Walmart, but I haven't seen that one.
Yeah, that was a joke. So BRCA is a mutation that is present in what we found, and how we found it, when we found that women who had first degree relative, like an aunt or a mother or a sister. So what we did, we went back to the lab and we looked at the DNA. What we found was there was a particular space in the DNA, which what we call DNA repair gene. It's called BRCA, BRCA. Those genes were mutated, and subsequently there's a test out there which we are able to do and tell the woman that they have a risk of breast cancer, and there is association of ovarian cancer with it also. So women who have a higher risk, or if say a woman comes to my clinic and she's 45 years old and she tells me that I have an aunt who was also had breast cancer.
Right.
So that can have consequences not only to herself. I mean, if she has breast cancer on one side, she can get another breast cancer on the other side, as well as she's at risk for ovarian cancer. And there are some other cancers which are associated with the same mutation.
Okay, well, I'm going to take a really quick break and come back, and I want to kind of pick up on that in terms of the genetic component that you're talking about.
Sure.
So, Dr. Muhammad, you stay put. Don't go to Walmart.
Okay.
Please stay put. We'll be right back.
Up to 40% of businesses never recover after experiencing a major disaster. Make a plan at ready.gov/business.
Welcome back. To continue our discussion on breast cancer, joining me again is Dr. Muhammad JanJua with University of Oklahoma Hematology Oncology Department. Let's jump in. Now, you were talking about sort of the BRCA and the genetic component to that. Let's say the woman comes in and she's having no problems. Maybe she just is getting a routine checkup, or she's wanting to sort of find out because she does know she's got this history in her family of breast cancer with the mother or the aunt. Are you going to do anything differently for her? Should she do something different?
Absolutely. And I'll give you an example. I had a 35-year-old patient who came in with her cousin because the cousin got diagnosed with breast cancer, and the cousin happened to be 45 years of age. So she started asking me, do I need, this is the 33-year-old, she said, do I need to do something to prevent that risk? So I did, given the age, the young age of that 45-year-old. Remember, you have to understand, 45-year-old is a baby in this, now the statistics. So I tested her. So what happened was we found that she did also have a BRCA mutation. So there are different consequences after you're diagnosed. We only diagnose after we provide counseling. You have to understand. You have to understand the consequences of that test. That with that, what do you do with that information? You have to understand the results of that, insurance-wise and otherwise. So in her situation, I had a discussion with her because she's at risk for having breast cancer. So we discussed whether she could potentially have bilateral mastectomy, because bilateral mastectomy will bring down the risk of breast cancer by 95%. There's always a 5% risk left behind. Also, the BRCA mutation that I mentioned to you also puts her at risk for ovarian cancer. So we discuss the consequences and the results with potentially if she needs her ovaries, if she's done with having babies and things like that. So there are definitely things that we need to discuss in detail regarding what we need to do from that point.
Okay, let me ask you this, because some of the possible consequences in terms of early mastectomies bilaterally or ovarian removal, removing your ovaries, can be pretty drastic.
Right.
And so let's say the woman says, you know, I'm really not ready for that level yet.
Sure.
Does that mean that she should have more frequent exams? Should
Absolutely.
she do more than the once-a-month breast exam? Should it be maybe weekly? I mean, what are some other intermediate possibilities for her to consider?
Absolutely. And then that's where the art of medicine comes in. We need to aggressively follow her. That means we do, if she has large breasts, we need to examine that not with a mammogram, because mammogram has been known to miss a few lesions. I mean, the few spots which are smaller or their situation. So you try to do a more aggressive, that means you do an MRI of the breast. So basically your surveillance will be a little more aggressive, because you know, it's like this, if you know a train is coming towards you, you're going to be making some precautions.
Right.
You're going to get off the road. So if you know that you definitely have a risk, you're going to do a little more aggressive surveillance. That means both with MRI of the breast. It's a difficult thing because reimbursement is a big issue. But at the same time, when you have the risk, the insurance companies are very understanding, and they let us do all these aggressive tests for active surveillance to make sure the disease doesn't come back or doesn't come in the 33-year-old situation. So in that situation, you aggressively monitor, and if you see something, you go after it.
Now, are there any medications that the person could be prescribed that may help delay this or prevent this? Is there anything that you can take that way?
That's a very good question. There are studies out there which suggest that women who have a hormone-positive breast cancer, if you give them a drug, what we call tamoxifen, if she's premenopausal, and raloxifene is if she's postmenopausal. If you give them those drugs in a situation, if the tumor is hormone responsive, you have to understand the breast cancer comes in 30 different flavors. They're like Baskin Robbins. And there are some flavors that it presents with that we don't even know. So we do the best we can.
Right.
And that's why we have clinical trials. So to answer your question, there are drugs. It's only in those situations where you have a hormone positive breast cancer. But in people who have the BRCA gene, it's mainly, and not always, but 9 out of 10 times, the triple negative breast cancer. Triple negative, what that means is, that means they have a negative estrogen receptor, a negative progesterone receptor, and a negative HER2/neu.
Okay.
Or Herceptin receptor.
So if those things are negative, does that mean that they don't
respond
as much to those hormonal
therapy.
kind of, those types of things. Now, let me ask this other question in relation to breast cancer, because there are many women who have very dense breasts.
Absolutely.
So should their surveillance be somewhat different, or the traditional mammograms every year? How should they view that?
And we come across this problem all the time because we have some women whose breasts are a little more denser. So what we do is we do an MRI. We cannot get a good imaging through the mammogram. A woman cannot forget a mammogram because the way it's done, it's so painful that you cannot. There are two things a patient cannot forget: is a bone marrow biopsy and a mammogram, because they squeeze the daylight out of you.
Well, pelvic exam too for women.
Okay,
Throw that one in there, doc.
I would recommend that also.
Okay.
But like I said, it is based on, if you the size, with the size, that's the limitation with the mammogram. So in that situation, you recommend getting an MRI, because MRI is a little more, it's basically the cuts that the MRI makes is so small that it picks up small lesions, and based on the size of the breast, you're able to cover pretty much everything. So breast cancer surveillance, and it's a clinical decision.
Right.
If the breasts are big and you're not able to cover that in a mammogram, so you do a breast MRI.
Okay. Now, how often should women have mammograms, and at what age?
So the different guidelines.
There's been controversy
very
about that.
controversial.
Yes.
So I'll stay with the American Cancer Society. 40 years onwards, you do an annual mammogram.
Okay.
So.
Okay, from 40 years annual. Okay.
Absolutely.
And
but if you're at a higher risk, or if you have a relative who was diagnosed at the age of, say, 25, you do it early. So because you know she presented with the breast cancer at the age of 30, you do it earlier than that.
Okay.
You want to catch something before it happens. So yeah, I mean, the jury is out. I won't get into the controversial part.
Right, no.
Because
But
I might lose my job.
We just want to get the general of what women need to remember. So
Absolutely.
from 40 onward.
40 onwards.
Yearly.
Absolutely. And there are definitely guidelines and recommendations. Remember, guidelines are, it's like this. I tell my kid not to eat candy. But does he listen to me? No. Okay, not really. Sometimes. So basically what we do is we also recommend, as a recommendation, for women to examine their breasts also. I tell all my patients, studies have shown that doesn't have a benefit, but I have patients who come to me, and studies are based on thousands of days. There's a physician who sits in a room and comes up with a number and says, okay, it doesn't do any benefit. But I've had women who tell me that, okay, I found a lump, and that's how I found it.
Right.
Do all women get mammograms? No. My mom doesn't listen to me. So she's had a bad experience with the mammogram, she doesn't go back. So, but if you do your own exam, you're able to pick up things also.
Right. And I want to say, too, before we take a break and come back and look at the types of cancers and breast cancers and treatment, that mammograms really, although they may not be comfortable, they're not really painful for the most part, and they're very quick.
Absolutely.
So we need to do that, because I'm a faithful believer.
Absolutely.
So when we come back, we'll talk a little bit more about the types of breast cancers and how do you treat them.
Sure.
All right. Please stay with us. We'll be right back.
Pants. I am folding the pants. Do they go on my head?
Everyday moments can become teaching moments, because learning starts long before school does. Give your child the start they need at bornlearning.org.
Welcome back. To finish our discussion talking about breast cancer, joining me again is Dr. Muhammad JanJua with the University of Oklahoma Hematology Oncology Department. Let's jump in. Now, you alluded in our first segments about different types of breast cancers, and you talked about ductal and if it's not hormonal responsive. Right. Go a little bit more into that, because you're talking about the Baskin-Robbins 30 flavors. There's all different kinds. What are the most common types that you see?
So breast cancer, like I said, comes in every different color. The most common one, and so 400,000 women will be diagnosed with breast cancer. 50,000 of those will have what we call ductal carcinoma in situ. Breast is a very, very beautiful creation of God. I mean, it's got ducts and lobules which finally connect to the nipple. So the cancer is basically where the cells which are inside the ducts, they start growing, and when they start growing at an abnormal rate, we start calling cancer. If you see it under a microscope, they start looking funny. They don't look like your regular vanilla flavor. It looks like something like maybe pistachio mixed with something else.
Okay.
So it's so basically what we do is we start classifying breast cancer according to the stage. So there are different ways that we can classify breast cancer. If the breast cancer the cancer cells just stay within the ducts, that means they're staying in a pocket,
Okay.
what we call ductal carcinoma in situ. So what we do is we resect that portion of the breast. That's what your plan. If we ask the woman, do you want to get a mastectomy or do you want to get lumpectomy, I mean, part of the breast out? So we take the part of the breast out, and subsequently we do radiation to the rest of the breast, and we put them on a pill depending on if the tumor is responsive to estrogen or progesterone, what we call tamoxifen. If the tumor extends a little beyond, and I'm talking about the most common one, which is the ductal.
The ductal type.
If it goes a little beyond that pocket, we call infiltrating or invasive, and that changes the picture a little more.
Right.
And depending on the differentiation of the tumor, the grade of the tumor, and the mitotic figures, and then all these other things come into play. If they're expressing an estrogen receptor, if they're expressing a HER2 receptor, or they're expressing a progesterone receptor. And then depending on all these factors, we decide whether that patient, the risk of the cancer is high to come back or not. So the first thing we do, and we skin this cat many different ways. There is no, if you see an oncologist in Oklahoma, we do things a different way. For example, people on East Coast will do it a different way.
Okay.
But there is a standard treatment. What we do is we figure out, we put in all the numbers, and we discuss that whether the risk of tumor is high to come back. First thing is first, unless you run a clinical trial which states that you give chemotherapy first. So surgery is the cure. Okay,
surgery is going to be the cure.
Either we do chemotherapy first to try to shrink the cancer and make it small enough to get it out, and then there are ongoing studies for that. But as a standard of care, if you're not on clinical trial, if you have a tumor which is probably 2 centimeters, I'm going to take it out, and then depending on the characteristics of the tumor, I'm going to discuss what can I do to prevent this cancer from coming back.
Okay, so if the cancer has sort of evaded the little pocket, it's coming outside, then that is a greater chance that it may come back. It's more difficult to treat, so that may lead more to the mastectomy.
Absolutely, and let me explain that. If the tumor stays in the breast, the life expectancy is with all the new treatments out there, women will live, 98% of the women will live beyond 5 years and beyond.
Okay.
If this is still in the breast. If the tumor goes to the lymph nodes under the axilla, it's a little higher risk. 85% of the women, that means all comers, who have some tumor besides being in the breast, which has been removed, including the lymph nodes, 85% of the women will be still alive. And if the cancer goes all over, that means everywhere, which is what we call stage 4, which is a higher risk. Even 25 to 30% of the women will be still living 5 years and beyond, because we have treatments which are targeted. Now we know how to attack the tumor cells to a molecular level. Back in the day, I say this to my patients, we used to use Clorox. Not exactly, Clorox, you throw it on the ground and hope everything gets killed.
Right, that's true.
What we found that over time, tumor cells are very smart. They start developing resistance. Things weren't working the way we wanted to. That's when we went back to the drawing table, and we made drugs which are targeting the tumor to the molecular level. So we're able to kill the stem cells of the tumor. For example, what we found is if a woman expresses in her tumor a receptor called HER2/neu, for which we had a drug, Herceptin. If we give, and that's everything in oncology is based on clinical trials, based on thousands and thousands of patients all over the United States in cooperative groups. What we found is if we, after the surgery, and if you're not on clinical trial, we do surgery, and then we start giving chemotherapy, because chemotherapy, the goal of chemotherapy is to prevent that risk of tumor coming back. Because you have to understand, women in America, they're going to live to 90 years of age. Men live to 85, so women will always beat us.
Well, we got to have an advantage somewhere, Doc.
So the goal is to minimize the risk from the tumor coming back.
Okay.
So everything and anything we do, the moment you see an oncologist, is your goal is to minimize that risk of coming back to almost nothing.
To extend the life expectancy.
Exactly. Or the quality of life. And that's a very, for example, women who were life expectancy was less than a year to almost a year with stage 4 breast cancer are living up to 5 years and beyond. Patients with breast cancer, and I was in Kentucky when I did my training there, we had women who were living 6 years and beyond.
Okay, let me ask you this when you mentioned that in our last few minutes here, because of the treatment modalities you've explained and kind of the targetedness of it. Let's say you have a woman who is younger, still childbearing, and who finds out she has breast cancer while she's pregnant.
Right.
Are you going to, and just tell me quickly, begin aggressive treatment? Do you wait until the baby is born? And then can she breastfeed?
Okay, very good question.
Really quickly.
And that's where the art of medicine comes. You have to see what the grade of the tumor is. If the tumor is of very aggressive nature, then yes, studies have been done on exactly the situation you're telling me. And that, because any question or anything that you can think of, people have done studies on.
Okay.
So women who develop breast cancer during their pregnancy, we have chemotherapy which is safe to the child.
Okay.
Absolutely. So if we can wait, if she's 7 months, yes, we can wait a little bit until the baby is born. But if she's 4 months or 5 months of pregnancy and the tumor, we can't wait 5 months because the tumor has
then
a
you may
risk
have
of,
to treat.
Exactly, depending on the aggressive nature of the tumor. So absolutely there are chemotherapies that we can do which are absolutely safe for the baby.
Okay, and then really quickly, yes, no, or maybe, could she breastfeed?
So
just really quickly, yes, no, or maybe.
If she was my wife, and that's how I like to think. Everybody has their own thing, but if she was my wife, I would say take a break.
Okay. Okay, and that's a discussion for sure to have with your physician. Thank you so much, Dr. Muhammad.
You're most welcome.
Well, that's our show. For Health Alert, I'm Pam Butler. I look for your questions, suggestions, or comments. Please write me at Health Alert USA, P.O. Box 50913, Tulsa, Oklahoma 74150. Or if you're on the email trail, please email me at healthalertusa@gmail.com. And also visit me on YouTube at youtube.com/Health Alert USA. And remember, visit your physician. If you have questions, please ask them. Don't be shy, and get all the information you need and the things that you can do to extend the quality of your life and the length. And get that mammogram. Take care.